Here you can see a perfectly AP view. The reason is you can see just as much. You see this spinous process here? See the white right there on the either side? It's the same amount of white, almost exactly on either side. That's when you know you're looking right at the face. The nose is perfectly looking at you. Same thing here, same thing here, same thing here, same thing here. We'll look at a few where it's not like it. This is a great picture. And what's great about it is that you can see the sacrum, you can see the ilium, you can see the SI joint. So if the doctor said, I want to do a L4, if you showed him this first, he would know there's the L4. Once you guys get a good relationship, say sometimes I'll walk in with Louisa or Lydia or Michelle, and I trust them. After a while, I know, I want to do L4. They've counted up, and they'll always, if it's not obvious, they'll want me to know that they know. So what they'll do is they'll focus in on the L4, but then they'll leave it not magged so I can see everything. So the first projection will be focused on L4 in the right position, but they'll allow me to see with that first picture the sacrum, so I know that they know. If it's totally obvious, then I will allow them. They may just project the first one to be magnified and perfect, and we just go from there. But as long as you can see the sacrum, you know where you are, because you know where L5 is, you know where L5 is, you know where L4, you know where L3 and L2. So sometimes, let's say we have a high one, like an L1 or an L2 or an L3. You're in the middle, it's magnified. You may not see the sacrum. The doctor, unless you guys have a perfect working relationship, or he does, you're going to want to show the doctor her or his sacrum so that they know we're in the right spot. If we do the epidural in the wrong spot, you can't trust the results. You may say, man, that epidural didn't work, even though you were in the wrong spot, thinking you were in the right spot, and you don't return to that spot. And the patient doesn't get relief. Okay, so I brought up an image. Let's have a look at this image there. Now, TG, why don't you just come here and look at this with me. Which one of these to you, and I'll give you the pointer, does not look like it's AP? Can you show me?
You want me to say what it is?
Yeah, sure. Tell me.
So I'm thinking L3 and
Yes.
L4 because they are actually going the opposite way. They're not straight. So they're more to the right.
And what are you looking at on the spinous process that shows you that it is AP? Like you're looking at, you see some lines, white lines, correct?
You see both of the lines on L2 you see both lines here,
Yep.
and on L3 and 4 you only see them on one side.
Correct.
Right here.
So what would you do? How would you move the C arm to make it so that those two specific segments were more AP? Just like looking here on the, how would you, let's say this is the beam. Would you move it more like this or more like that?
More to the right.
Yep, that's exactly right. So you'd move it more like that, and then all of a sudden you'd see the sclerotic line on this side and on this side better, showing you that you are indeed AP. That's exactly right. Good job. What we're talking about is an interlaminar epidural. An interlaminar epidural is different than a transforaminal. It's different in that when you have the spine, what you can imagine is a spinal column, and dura and the sac is like literally like a says that we get medicine in front as well as in back of the sac. Okay, that's the idea. And that's why it works a little better than an interlaminar for a pinched nerve in the side. When we have a pinched nerve, say this is a herniated disc, it's always going to be pressing the nerve root in front. It's never coming from the back pressing in. And so the closer we are to the pathology, the better. But sometimes, and especially it seems with spinal stenosis, an interlaminar epidural works even better than a transforaminal. So the idea is that instead of coming from the side, we're going to come literally from top down. Now, so it means that the patient's in essentially the same position, but our projection is going to be AP. And again, if we can put a pillow under there to open up and bend the spine, you'll have even more space to get into interlaminar. What we generally do is numb the skin, put the needle down to the bone, and then walk off into the ligament of flavor, and then use what we call loss of resistance technique as we pass it through. But from a fluoroscopic idea, the concept is that you want to be basically just on the exact plane as the disc. Okay, and if that disc is sharp, we call the end plates of the vertebral bodies. This is an end plate here. This is an end plate here, on top and on bottom, just before you get to the disc. If those are crisp on that segment that you want to do, then you're going to be in good stead. So let's say you wanted to do a this is 5, 4, 3, 2 in L23 interlaminar epidural. You'd come and you'd have the spinous process of L3, spinous process of L2. They'd be nice and sharp, right, because they're looking right at you. And you'd want the disc right here, so the inferior end plate of L2, the superior end plate of L3 as crisp as possible. Let's just take a floor shot. This spine will do that. So try and take someone in. So you see what Michelle's doing here. She's moving that seam. First she's going to go up and check to see if this makes it more clear. It doesn't. So now she notices that it doesn't, so she's going to try more caudocephalad angulation. It's better, right? Now you can see space between the discs right here. And maybe even a little better. Let's try it a little more caudocephalad. That's even better. See, now this disc is even wider and thicker. Maybe even try going a little extra, a little too much, and just see what happens. It may make it better, it may not. Nope, it didn't. So we're trying to find that perfect spot where the disc is crisp, okay? And you can see it on this projection here. So we're going to talk about interlaminar epidurals, which is where we put the needle through or between the lamina, hence interlaminar, between the two lamina. And the lamina are the back part of the spinous portions here, the posterior elements we call them. And on either side of the spinous process, we have a lamina. It's that flat part. And the concept is to come down and touch the lamina and then walk into this ligament that separates the two, called the ligamentum flavum. So we come over here. The idea is that we have the best angle, and again we're trying to approximate the skin. Okay, that gives us the flattest angle. So Evelyn, just looking at this picture, you know, we're trying to get great end plate approximation, and we want sharp or crisp end plates. So looking at this image, can you show me a crisp end plate?
I would show you this one.
Yeah, that's very crisp.
That's
I totally
very
agree.
crisp.
Any others?
Bottom here.
Yep, that's very crisp.
And
What about the end plate here? Let's call this L5, the top end plate of L5. Crisp or not crisp?
Not crisp.
Correct, not crisp. You're exactly right. So looking at this picture and criticizing it, you know, I would look at this and I would say, this is probably not the angle that's best for this epidural. Had the doctor been wanting to go here at say 3-4, now that's nice and crisp, and we can see the interlaminar space quite nicely. But that interlaminar space really is between the bottom of one spinous process and the top of the other. But the doctor will likely start over the bone here, walk down to the bone, and then that will let her know the depth, and then the doctor will walk into this interlaminar space and then through the ligamentum flavum. So the concept is you want to be AP, and you want to have the disc as crisp as possible, because the disc is this thing you can't see that's separating these two vertebral bodies, because you can't see disc on an X-ray. Make sense?
Makes sense.
Oh, good job. You had a question about the spinal cord.
When you do a interlaminar epidural, how close are you to the sacral spinal cord? I know you're going lateral to it.
Well, in interlaminar, not necessarily. So a good question was asked on, with the interlaminar epidural, you know, what's going on? And so the idea is you place the needle down to the posterior lamina here, you walk. The next thing you go through is called the ligamentum flavum. That's a ligament that goes between the lamina. And then once you're through the ligamentum flavum, you're in the epidural space. What that means, epidural, means outside epi, dura, which means tough in Greek. And so you are between the outside of the thecal sacra dura, but inside the spine. And so I always make the analogy, it's kind of like if you took a 2-liter bottle and you put a balloon inside the 2-liter bottle, you blew up the balloon inside that 2-liter bottle, and then you tie it off. So now you can't go beyond the size. You can't make that balloon bigger than the 2-liter bottle because it's confined by the 2-liter bottle, but you can make it just the same. So you blow it in there and you tie it off. When we're doing epidural in interlaminar, we're putting the needle through the plastic of the 2-liter bottle, but not so deep as to pop the balloon. If we go too deep and we're inside the balloon, then we're inside the intrathecal space. And the totally different things occur. When you inject steroid or inject medicine intrathecally, it's a totally different response. Sometimes if you put the steroid inside the intrathecal space, you can get clumping of the nerve roots, arachnoiditis. You hear about these. That's why we use, no preservative in any of our epidural steroids that we use, or no preservative in any of the medicines that we're going to put even near the spine. Because those preservatives can cause scarring inside the spine. So never do we use any type of preservative. When we're going close, we could put it intrathecally. The other thing is sometimes we want to go intrathecal. It's kind of like an interlaminar epidural, but just one layer deeper. And the way you know that you're intrathecal and not epidural is because when you inject that contrast, it's a totally different pattern. The contrast epidural is spread out quickly because it's a plane between two surfaces. But when you're inside the bag, it just either blobs or it actually forms around the nerve roots. You see a strain where it looks like a hair, okay, and that's the actual nerve roots. So the question is, how close are you to the spinal cord? So let's say you're in the neck. We know the spinal cord goes all the way from the top of the base of the skull all the way down here, and it stops at
L1, L2.
L1, L2. Most people sometimes T12. So if you're in the thoracic spine doing an interlaminar, you're over the cord. You go too far, you're going to go into the spinal cord. Same thing in the neck. You go too far, you're putting that big needle right through the spinal cord and that's it. Lumbar. We talked about why do we always do an LP in the lumbar spine is because if we're going to go too far. That's the idea. We're going to go too far. We want that fluid. We know that these nerve roots are there, and these nerve roots are like, sticking your finger through hair versus sticking your finger through the head. The hair will part, the head will not. Okay? And so that's what you're banking on, is that these nerve roots will move out of the way as you put the needle in. Again, keep the patient awake. They say, it's going down my leg. It's not. Respect what the patient's telling you. That's a great question. So you're close. If you look on the MRI, and we always do, we see the cord, then we see that CSF collar around the cord. On the outside of the CSF will be the dura. We don't really see the epidural space because it's really like trying to see the space between the balloon and the 2-liter bottle. We're talking about facet joint nerve blocks. The whole purpose of a facet joint nerve block is to numb the nerve. What does the nerve go to? The facet. Correct. The facet is the joint. It's also called the zygapophyseal joint. And the idea is that it's a diagnostic, occasionally therapeutic way of numbing the joint up. The reason we do it is because we want to know if the joint is the cause of pain. If we numb the joint, the pain goes away, the joint was the issue. Or whatever was in the distribution of the nerve was the issue. So the nerve goes to the joint and a couple other structures, but mostly the joint. So the way we do a lumbar facet joint nerve block is, again, the way I do it is a little different than most people. Most people, if you're going to do, say, 4 nerves, you're going to use 4 needles, or 3 nerves, 3 needles. I use 1 needle for everything. And I simply direct it to the spots we're going to go through 1 skin poke, which is a little different than what most people do. But the idea is, if we know where the target is, then you know how to set up the procedure. So what I do is I start at the transverse process of L5, then I go to L3, maybe also L2, and then also down to S1. Whatever you're going to do, whatever the doctor's going to do, hopefully you're going to do the same thing every time so that they can predict it, and the fluoroscopist doesn't have to be searching, and once they know the pattern in the dark, and it's not incumbent on you to know that, it's incumbent on the doctor to tell you. So don't feel like a klutz, it's the doctor's responsibility. But the idea is this: the nerve sits in the groove, okay? Right here, and you can see we've marked it in over the years, this little line there. And it is a nerve that connects off of the main nerve, wraps back here, and then it goes right up here to this portion of the articular surface, and then at the other half of it goes down to the inferior portion, okay? Right here, where it's going to go to the next joint. So one nerve goes to 1/2 of 2 joints. Each joint has 2 nerves that go to it. So like from this joint, it's going to be a nerve coming from here and a nerve coming from here. But if we go here, we get the nerve before it splits. So the idea is to put the needle right here, 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 right, all the way up and down. If we put the needle there, we know with a high likelihood that the nerve will also be there, because we've done enough cadaveric dissection on enough people to see this commonly in the same spot. And then that's where we want an injectable numbing medicine, right here. So the idea is to give a good view of the transverse process, however the doctor wants. Usually it's AP. If you give an oblique, they can see it as well, like this guided dog. But again, the lineup is to, again, approximate with the angle of the spine sweeping, cephalocaudate for the high lumbar, probably caudocephalad for the lower lumbar, and at L4 it's usually what? AP. That's exactly right, for most people. So, but that's the idea for facetral nerve block. Same idea with an ablation, because an ablation is the exact same placement of the needle. With the ablation, what we really want to do is we want to take the actual the last tip. You know that when you look at the needle, there's that shielded part, and then there's the tip that's not. We want to place the tip along the actual path of the nerve. So if we come, say, top down and have only the tip, the lesion isn't caused at the tip of the needle. The lesion's caused along the actual path of the nerve. It's a spindle-shaped lesion. So the doctor really should, and this is probably the biggest error that most doctors make, is they don't place the needle along the actual path of the nerve. The nerve is lying flat on this bone. That means the needle should be coming from down to up, like this. It should not be top down. So if you see a guy going top down on here, you'll know in your mind it's probably not the best projection, not the best results. You want to get as flat as possible. And it's why really when we're at L2, do we see the biggest twitch? We see the biggest twitch at L2 when we do that sensory testing, because we're usually lying as flat as humanly possible to that nerve. You'll see it there. But that's a facetral nerve blocking ablation on the lumbar spine. Again, you moving the C arm, caudocephalad when you're in the low, cephalocaudate when you're in the high lumbar spine.
So for what you just explained,
Yes.
because I don't know, I always thought that when you do the facet nerve block ablation that you're hitting these nerves, so it's always the nerve that's on top.
That is an excellent question.
Oh, okay.
And that's such an important thing to recognize for a lot of reasons. Number one is, if the needle is, say, too far close down to what we call the spinal nerve, okay, this nerve joins the plexus and it forms the sciatic nerve and goes down the leg, or the femoral nerve. If you ablate this sucker, you will paralyze the patient, okay, or really injure them in a big way. And it's generally not reversible. So all the more importance to make sure that when and we'll take a lateral off, and we want to make sure that the needle is not anterior down here next to the disc or the pedicle where their nerve is coming out. If the patient is asleep, sedated during an ablation, and you don't have the patient awake to tell you, yeah, I feel that in my leg, or when we do the motor testing, I feel it in my leg. That's a great question. I'm glad you asked. The other reason is, so we can do a sensory and a motor test. I don't do the sensory as much because radiographically we know we're in the right place, but what really matters most is always safety. So we do the motor every time. And what we're doing is imagine the tip of this is the unshielded portion of the needle. If the needle is in the correct location, posterior, you're just sitting right there in the groove of this bone, it is not close enough to this nerve which goes to the leg. So when we turn up the motor stem, we'll get twitch of the little muscle here in the back that comes from this nerve, the medial branch, we call it, but not the main nerve. If we're too close to the main nerve, it will also cause a twitch down here, and you'll get a twitch in the leg. Conversely, same thing in the neck. If you're too close to the nerve coming out that goes to your arm, you get a twitch in the arm. No twitch in the leg means you're safe, as long as the machine's operating perfectly and properly. So, in the idea between the motor and why it's safe is, I tell patients or people, if you want to tell a secret safely, and you know you're the right proximity, if you yell and no one else can hear you, they'll never be able to hear you when you whisper. So the motor is a big, large area. We're broadcasting 3 to 4 times the size of the lesion. Okay, so we know that we're safe. It's like the safety circle when you're working with a knife. You know if you're out here, you guys can't get cut. Wood on wood, you're outside the zone. And if we do the motor testing and we don't get the twitch from this nerve, we know that we're going to be inside the zone when we do the ablation. So that's why we do the motor twitch. But you're exactly right. This is not what we want. this is what we want. And that's also important in terms of coagulation. So when a patient comes and they're on Plavix, and they say, I don't know if I can have that procedure, if you are going inside the spine where there's blood vessels, no procedure, because they might bleed and cause a big compression. If you're in the soft tissue, away from these nerves where there can be compression, they might have a little bleeding, but it will not be of much consequence because they'll just bleed and they'll eventually stop, but it won't cause nerve compression. That's the difference between the epidurals and the facets with bleeding. If we go down deep, put a needle inside the spine, and you nick a little blood vessel, they'll bleed and bleed and bleed and bleed and bleed, and ultimately get into the spine, compress the spinal cord and the nerve roots. So, let's talk about the sacral stuff. The sacrum is just the base of bone right at the bottom of the lumbar spine. Occasionally we will want to do an epidural in the sacrum, or for a sacral transforaminal. These are the foramen. You can see these holes. You know, there's probably 5 of them, at least 4, often 5, occasionally 6. Okay, and each one, the S1 nerve comes out of the S1 foramen, the S2 nerve out of the S2 foramen, S3 nerve out of here. And if you look at the spine, okay, you can see. Here's the patient just standing up. Here we are. If we are AP, we're not going to see through the S1, right? We probably won't even see through the S2, but we will see through the S3. So what do we have to do? We have to go caudocephalad to see S2. We have to go even more caudocephalad to see S1. If you see the patient standing like this, here's the beam angle, okay? Which means you've got to really be very caudocephalad because we're projecting up through here to see that hole, right? It's hard to see through there. But you got to have a big angle. If you're top down, you won't make it. So the sacrum is pretty easy. You're always AP, okay, just like that, but you're having a lot of caudocephalad angle. You have a question, Evan? Okay. The more low you get, let's say you're doing S3, you can be a little less caudocephalad. You may even be AP. S4, you may even be cephalocaudate, okay? Now, there's one type of epidural we do called a caudal. And sometimes if we're going to do adhesiolysis, we'll also come through the caudal canal. Sometimes we can put spinal cord stimulator leads through the caudal canal. You can't see it on this, but this thing is called a sacral hiatus. We just saw this yesterday. We were doing a caudal. And there's something called a sacral cornu. Okay, and the cornu just means a horn. Okay, here on either side, you can feel it in a thin patient. You can feel this, and right in between those cornu will be the sacral hiatus. And what do we see here? It's just basically ligamentum flavum, for lack of a better term. Put the needle in here and you pass through. So the easiest way for you guys to help the doc is, you're not going to need, an AP is hard to see this. The best projection is you will see the difference, okay, in a lateral between just the coccyx in here, and then it gets much thicker here. So if you see that difference on lateral, you know that the needle is going to come in right here and you can come right through there. So I always start the caudals in the lateral position. Cross-table lateral, so then I'm looking here, and not to give away all my secrets because it took years to figure this out, but you can project the needle perfectly if you feel the anatomy, hint to any doctor watching it. So if you feel the anatomy of the lumbar spine, that'll tell you your exact angle. You don't ever need to go to an AP projection. Okay, you just go in the lateral, and then once you've got the needle in and the catheter in, you can go back to the AP projection to follow the catheter up. Any questions? So in the thoracic spine, we're going to do, if you're looking at the thoracic, look at the lumbar first, because we're going to go faster on the thoracic than we did in the lumbar, just because a lot of the concepts are the same. We're going to talk about facetral nerve ablations, blocks, transfer epidural steroid injection, intercostal nerve blocks, and an interlaminar epidural. Those are the most common things we do. So in the thoracic spine, there's a little difference. The difference is, if you look at the transverse process, it's all very variable. Out here, you can see it's kind of the same in the lumbar spine, okay? But there's all kinds of different shapes to the transverse process in the thoracic spine. The other difference that we know in the thoracic spine is that the central nerve, okay, or the medial branch of the dorsal primary ramus, the nerve rafter, is variable. The guy who did all these dissections, they're very similar between individuals in the lumbar, very similar in the neck and the cervical spine between individuals, but in the thoracic spine, you know, Evelyn and Dominic, there may be totally different spots, you know, and that's a problem for us because we don't have that type of reproducibility based on the anatomy. You may have one nerve that sits here on one person and one that sits out here on this person. And so we actually use a little larger injectate. I actually come across the midline when I do it. But the concept is the same. Generally what we want to do, position the patient accordingly. Again, you want to keep the image intensifier parallel to the skin. If you're in the high thoracic, you're going to have a little more caudocephalad. Low thoracic, maybe a little more cephalocaudad. And you're going to basically count. And that's really important. The hardest thing to know is, like, where are you? Because the image is so small that you can only see a patch of the thoracic spine. You don't know if this is the T3 or the T7. Okay? So you, again, have to start by showing the doctor either the lumbar or the cervical levels. Maybe even best to count down in the thoracic since there's more variability. But you show them the base of the cervical spine, and then you can count the ribs as you count down. So let's say you can do T7, you count down to the 7th rib, or even you'll see the rib comes right under here. There are no ribs on this, obviously. But the idea is to, again, project where you're going to go. And often what I'll do with these, I'll do a separate skin code for each one. Okay, because then I know I'm coming down here, and I'll come right to the posterior portion of the transverse process. I may even march across the transverse process and numb a little bit across. It'll kind of like leave a little line of numbing medicine across there. When I do the ablation, I want the needle to go across it as much as possible, so that I get the flat part of that needle against or across the nerve, so I get a good ablation. With the transforaminals in the thoracic spine, we are worried about, anyone remember?
Artery.
The artery of Adamkowitz. That is exactly right. 10 extra points. The artery of Adamkowitz, and it's much more prominent on the right or the left.
Left.
The left. Not always. It can be anywhere. But we know, remember when we were talking about the foramina, in the foramen, what comes in and out the superior portion that you don't really see in the inferior portion? Do you remember anything along those lines? The nerves and vessels come in the superior. So when you look at the foramen from the side, you can see in the superior portion, the high part, this is where the nerve is going to be. It's going to be where the nerve, artery, and vein most likely are. We look at a bunch of projections. Very rarely do we have anything going in or out of the base or the bottom of the foramen. So if you're going to do an epidural in the thoracic spine, we almost always do this discal view, okay, where the disc is on plane, like a retrodiscal epidural. So what you do is it's really important to have the disc crisp, okay? Then you come with just a tiny oblique, because what we're going to do is we're going to walk the needle down here, and then we're just going to go right up next to the base, and maybe even wrap it into in front of the superior articular process here, so that we're against the base of the disc. If we're against the base of the disc, it can be really hard to get the artery. And that's the way I do an interlaminar, or a transforaminal. The interlaminar is, again, the same idea. You want to get as much space, okay? And this may be different because the space between the lamina may not correlate with the disc here. Because you can see the disc is at one angle, the lamina is at a different angle. So with this one, you're going to have probably more, if you're in the low, you're going to have more cephalocaudad, okay? Even in the mid, even more cephalocaudad. Because look, now looking through there, the only way to get the needle underneath there, right, it's tight. You've got to walk from this angle. You can't come top down. It's guarded and protected, okay? And it's even same here in the high thoracic. You're going to want a more cephalocaudad angle so you can see underneath and see that little hole. But that's the hole. That's where you want to put the needle. So you're going to, again, just the, like your eyes are viewing at this angle, you don't have the C arm viewing it at this angle. Okay, so cephalocaudad. Does that make sense? If you're going to go to the cervical spine, there's usually a pretty good space here around C7, T1, or T1, 2, or even T2, 3 where you can get the needle in. That's the interlaminar. Same concept that was the lumbar. With the intercostal nerve block, the idea is that you start here and then you're going to simply, you got to again count the ribs to make sure you're going after. All right, we're just talking about wings, so we got to get our heads wrapped around cervical spine, which is what we're going to talk about next. So cervical spine, the idea is facet joint nerve block, facet joint nerve ablation, transforaminal, interlaminar, a facet joint cortisone injection we're going to talk about, the AA joint, the C2 ganglion, and a stellate. There's a lot actually going on in the neck. Neck is a little more dangerous than the rest because we've got some arteries. And those arteries are going not only to the cord, they're also going to the brain. And we want to avoid those arteries, or at least we want to know when we have a needle in the artery. So the best way for you guys to think about the neck is, you know, for a facet joint nerve block, we'll start with that. We generally want an AP view. I do, and Dr. Wu also does. in the AP view, and then we want a cephalocaudad angle for the most part. And the reason we do is if we look at this, we look at that, there's something in, and this is big, is magnified on the screen in a big way, but you can see something that's common on the lateral portion. It's this little indentation. We call that the waist. This is called the articular pillar. We call this the waist of the articular pillar. And that is where, you see right that little line, the medial branch of the dorsal primary ramus lives, the facet joint nerve lives. So the concept for us is if we have this cephalocaudad angle, then we can see the joint, we can see the waist, the joint, waist, very easily. And then the doctor put the needle down to the bone, walk it around laterally where it's safe, next to the nerve, and then you see this red thing in there, that's the vertebral artery. We don't want to put it there. The idea is we want to put the needle tip right here, etc., all the way down. But if you have a little more cephalocaudad angle, you'll see that waist rather clearly. Sometimes you have to judge that orbital travel angle a little bit, and it may not be. In some patients, it may be up-down. In very rare patient, it may be even a little caudocephalad. It just depends on that level. But if you're looking for the waist of that articular pillar, that little sulcus, that little indentation, that's what you want to project to the patient. You can see there's a lot going on in a small area. Down here, just a couple spots. This is the whole cervical spine in two lumbar vertebral bodies. So the idea is that here on this side, here on this side, some people will do a lateral projection, okay, for their facet joint nerve block. I don't happen to like it because just anterior to it is the vertebral artery, the foramen, the cord, and if you're off a little bit, it's a big deal because you're in stuff that really matters. So I always come down posteriorly because if I'm over bone, I know I'm never going to injure anything. That's the whole idea. Same thing with an ablation. Once I walk down to the bone, I walk it just lateral. Then we do our motor testing to make sure we're not too close to this spinal nerve that goes down and into the arm, for example. If we're too close to the spinal nerve, will cause paralysis or arm weakness, etc. Sometimes after the procedure, a patient may say, well, I have some numbness in my arm. And I used to use Marcaine. That's 8 to 12 hours of numbing as a nerve-wracking thing, because then you don't know whether you hurt the nerve or you just numb the nerve. So now we just use the lidocaine, because now in an hour you're going to know the answer. But if they have a little weakness, our hope and pray, of course, and thank God over the thousands and tens of thousands that we've done, we've never had an injury. But if you're too far, what sits right here is this segmental nerve that goes to the arm. You have weakness, just like with the leg, if you were to do it that way. Or if you were to do it in the thoracic, you'd injure the nerve coming underneath the rib. You could have all this pain wrapping around. You want to avoid that. That's why we do the motor test.
Did you say anything about turning the neck?
Yes. Okay. Yeah. The other thing we do with the facet joint nerves is we ask the patient to turn to the contralateral side. And if they do that, not only do they move the jaw out of the projection of the X-ray, now we can see things really well, it also turns and protects the vertebral artery from the needle because it turns it away. And it also makes it easier to see the waist of the articular pillar. So we'll have it turn to the opposite side. Good point, Jeff. Same thing when we do a transfemoral, turn to the opposite side to protect that vertebral artery. An interlaminar is almost always done at the base of the cervical spine and extremely rarely done above the base of the spine. There's got to be a really extraneous reason for me to do it at the, up here. The reason being is just a lot more vessels in there. And if I'm going to go do a transfemoral high, I'm going to use a needle with a catheter from the inside out. So interlaminar, same concept, base at the cervical thoracic junction. A facet joint cortisone injection, same concept. Again, cephalocaudad angle, and if you look here at the joint, you see how it's a shingled angle like that. Again, we want the needle to come in like this. You will never get in if you come top down. So you have the angle of the X-ray. Again, cephalocaudad, so it's coming right up so that you can see right into that joint, just like that. So that's the angle. The AA joint, I'm actually going to leave that off. If the doctor wants you to do it, he'll show you how to do it. C2 injection, similarly, stellate. The stellate ganglion block is really somewhere around C6, C7. It sits in the front part, so we place the patient in the what position? Supine position. We project the C arm so that the doctor can see now the patient's turned over like this. Again, now we're trying to have a discal view. Okay, so we're going to have a cephalocaudate. We're not worried about. We think about the neck always in a, looking at the facets. This is the one time we're not thinking about facets. We want the discal view, so we want the disc to be en face, is what we call it. The idea is to come down to the base of the cervical spine. You have the patient turn their head just slightly away. Then the doctor is going to put their fingers down, feel the carotid, push the trachea away in the esophagus, and then you're going to basically put the needle down between the trachea and the esophagus and the carotid. And then you put the needle really on the front part of the vertebral body a little laterally to a place called Chassagnac's tubercle, which is this little thing right there. And then that's where you're going to do the injection. You should see the contrast kind of flow up and down there. It's one of those very freaky procedures, and done incorrectly, you can really mess someone up, but if you know what you're doing, it's actually a very, very safe procedure. So lastly, advanced concepts with the C arm, just a few housekeeping terms. How do you deal with metal? So let's say you have a patient who's got a lot of metal in their back. It's sometimes difficult. So let's say we're going to do a lumbar facetral nerve block. Often, what happens with the metal is the metal doesn't permit the X-ray to come through, so the C arm responds by pushing more energy, and it over-penetrates the bones, and of course you're not going to push it through the metal, so it just remains a black blob on the screen. The concept is if you use the collimation to move the metal out of the way, then you'll get an appropriate amount of exposure. So try to do that for the doctor. Additionally, with the hardware, sometimes, let's say with a facetral nerve block, you want a little lateral, oblique view so that you can see around the head of the hardware. There'll be a screw, like a pedicle screw, sticking right out here. And it's really hard to get here, so from this projection. So you just give the doctor a little more oblique, and he can place the needle down around the hardware sitting here to the transverse process. Sometimes the process will be injured, or they'll try fusing all this, it will be messed up by the surgeon. But oftentimes you can actually still do the facetral nerve block just going around the actual head of the hardware. When you store the C arm, the way you want to store it is you want to bring everything in tight. You don't want the arm sitting out like that. You want it in tight, lock it in position. You want everything set in position and locked, and then you move it out of everyone's way. You want everything just basically to be in a neutral position when you store it, then you turn it off. One last thing, what was it? Resetting. Occasionally, the C arm will have a malfunction. There is an important button on the C arm for you to know, and that is this red button here. Okay, it's on either side. Let's say, for some reason, it just starts taking pictures. You're beep, 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 beep. It's just fluoroing. It's bathing everyone in radiation. That's your button to turn it off. Okay, you also have that green light on the front of the C arm. Turn the thing off. Also, additionally, if the doctor may be standing on the pedal inadvertently and not knowing it, not paying attention, beep, 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 and the doctor is having a very important conversation, you interrupt the doctor. It doesn't freaking matter. Okay, he is irradiating everyone irresponsibly and hurting everyone, you and the patient and himself. Interrupt him, push him away, turn this thing off, whatever it is. If he's doing it incorrectly, you don't want to hurt anybody, so that's also your responsibility to protect everybody. I think that wraps it up. Thank you guys for watching. This has been C arm basics with cervical, lumbar, thoracic, and other anatomy, how to do certain procedures, how to operate the C arm, and accompanied by our staff, Michelle, Dr. Abdul, and Evelyn, and Taiwana, and then our excellent PAs, Dominic and Jeff, who's, of course, off arguing with an insurance company. Thank you for watching.